do it in Washington, D.C. There's a lot of think tanks that do that in Washington. We needed one here in the Heartland, and so the Heartland Institute was born. And 2 years ago, almost to this month, I suppose, it was August of 2015, we moved from, well, I should say we escaped from the city of Chicago and made our way out here to the sunny highlands of Arlington Heights, Illinois, in the northwest suburbs, where we feel a little bit more welcome and certainly feel great to have so many people up here in the northwest suburbs of Chicago who take time out of their evening to come to fantastic public policy events such as this one. We're a think tank. We're in the ideas business. And we see from the current debate over Obamacare in Washington, D.C., that the world needs a few more good ideas. They seem to be stuck on stupid, as I heard some general say one time, or a FEMA person say at one point. And so it's good that we have someone here today who can get at least the people in this room a lot more informed, and perhaps if they're watching in Washington, D.C., get them stuck off of stupid. If you like what you see tonight, and I hope you do, either watching online or here in this hall, I encourage you to look around our website, which is heartland.org. You can check out our blog called The Freedom Pub. You can check out our daily podcast on iTunes. In fact, I did a podcast with our guest tonight, which will be a little bit more of an interview format than his presentation tonight about the state of healthcare in this country, and that'll be published either probably tomorrow or Friday. We're on track for 2 million downloads of our podcasts in the calendar year of 2017. Something we're extremely proud of, and that's because we put out a good product. So I hope if you like listening to podcasts, summer is the time for driving across the country. I did that actually last week. I listened to a lot of our own podcasts and others. It's a great way to get informed, pass the time, and really, I enjoy them, and I think you would too, on your road trips this year. And I also want you to stay tuned. We're going to debut a new podcast later this month or next month, and so stay tuned for exciting news about that coming up in the coming weeks. You can also check out our YouTube page where this presentation is being live streamed. Also on our Facebook page, it's being live streamed. And all the presentations here, if you've missed any, can be viewed on our YouTube page as well. It's a great place to check it out. I have a smart TV at home. I watch it on the big screen. It's a lot of fun, and so I hope you will too. And if advancing freedom and liberty is important to you, and I know it is to everybody in this room, and I hope it is to people listening to me and watching me online, I hope you will consider joining the Heartland Institute as a donor. The programs we put on here, the work that we've done for 33 years, it's not possible. We're a 501c3 nonprofit organization, and without the support of people who believe in liberty and free markets like we do, we're not able to do the things that we've done for more than 3 decades. And so there's information on your tables about how to do that. We have a very convenient electronic way to donate called the dip jar on the door on your way out. It's set for $10, but you can just keep going in and out like that for 10 or 15 times if you like. And that really helps us keep our program strong and keep people working hard for liberty here at Heartland. And before I introduce our speaker for tonight, Ariana Wilkerson, our Government Relations Coordinator, has just a few words to say about the work that they do here for Heartland. Ariana.
Hi, everyone. Hey. My name is Ariana Wilkerson, the Government Relations Coordinator here at the Heartland Institute. Heartland is unique among think tanks, as you know, in that we are a national organization focusing on state-level policy solutions for all 50 states. We currently have due-paying lawmakers of our legislative forum in 39 states. The goal of government relations is to make Heartland the go-to resource for policymakers and to help educate state lawmakers about what they can learn from the policy successes and failures from other states. We do this by 1, sending experts to testify before committees, 2, hosting educational events for lawmakers, and 3, providing on-demand research from the top experts in the country on a wide variety of policy issues. This year, we have already testified in 11 different states, and our biggest event of the year is our Emerging Issues Forum in November in Houston, Texas. In regard to the healthcare issue, Heartland urges states not to wait on Congress to repeal Obamacare, and instead move forward on submitting waivers to Tom Price and HHS for flexibility. We also urge states to roll back burdensome regulations, such as Certificate of Need laws, expand access to dental care with dental therapy, and allow direct primary care to flourish. And of course, please check out heartland.org to learn more. Thank you.
Thanks, Ariana. And before I introduce our speaker, I wanted to just recognize a couple VIPs in the audience tonight. Right here in the center, where he usually sits and causes trouble, is Jim Johnson. He's one of our founding board members of the Heartland Institute. Raise your hand. Applause for him. In the back over there is our Chief Executive Officer, CEO, Joseph Bast. And Joe only has half the title that he used to have because the Heartland Institute has a new president. And we debuted him in an event last night, and he's here again to see tonight's program. That is a former three-term congressman from Kansas's 1st District, a rock-ribbed conservative, a leader of the Tea Party movement, Mr. Tim Hulskamp, Dr. Tim Hulskamp. So he's fantastic. We're very excited about the direction that Tim is going to be bringing to the organization day to day here in the office. And so this is an opportunity to get a chance to meet Tim. You're going to see him here a lot, and that's going to be fantastic. So welcome. All right, our speaker for tonight, talking about healthcare policy, is John Garven. He is the president and founder of Beneco Limited, an employee benefit brokerage and consulting firm based in the Chicago area. He's a graduate of Trinity International University. John founded Beneco Limited in 1981. At the end of last year, he merged this company with 23 other firms, becoming a founding partner in a new financial services company called Alera Group. Since 2005, the Heartland Institute's been honored to count John as a policy advisor covering healthcare issues. And on a personal note, John and his wife Pam are lifelong Chicago area residents, and they live in Huntley and have 2 adult children and 4 lovely grandchildren. To speak about the state of healthcare today and hopefully get us cheered up about it, please welcome John Garven.
Well, thanks, Jim. I don't know about the cheering up part, but we'll see how things turn out here. So I really appreciate the opportunity. Thank you, Joe and Diane, for what a great organization Heartland is, and also Jim for having the vision to launch this 34 years? Yeah, it's awesome. So at any rate, again, as Jim mentioned in the introduction, professionally I'm an employee benefits consultant. I work with companies and organizations in helping them design and communicate, enroll, and comply with government regulations and requirements for all their benefit programs, including health insurance. So I've been professionally engaged for a good long while in the health insurance industry. We work with companies from very small size to our largest company with about 6,000 employees. But most of our clients tend to be in what I call the middle market, companies with 50 to 1,000 employees. I've been really interested in policy with healthcare since Hillary Care 1.0, 1994. I've been a member of a national trade organization called NAHU, which stands for National Association of Health Underwriters, actually my entire adult career. Actually, it's kind of a funny story. I've actually been a member since 1978, and about a few years ago, I got a plaque from NAHU saying, 25 years as a member, and it was 2005, so that would have been 1980, and I called them to explain, well, thank you for the recognition, but really I joined in 1978, and the person kind of embarrassingly said, sir, our records don't go back that far. No, but seriously, NAHU's been a very big part of my career. It's really helped form who I am professionally, and I really appreciate that. Pam Mitroff, a colleague of mine, is here tonight. She's a virtual employee, lives in Wheaton, but is on the NAHU national staff. As far as my involvement in policy, in 2004, then State Senator Barack Obama passed a bill in the Illinois Senate called the Healthcare Justice Act. And interesting story there. Of course, everybody here is from Illinois, lived here for a while, right? We know how broke we are as a state, and that hasn't changed much over the last few years. So they didn't actually get appropriations for this bill until 2005. And at that point, about $2 million was appropriated in the state budget to finance a study, a task force. In fact, Pam was one of the members of it. I wasn't a member, but I was part of the insurance industry working group. There was 29 members of this thing, and the whole idea was, and it was all these different stakeholders. You had consumer advocates, you had people representing government, healthcare, what have you. And the whole idea, the premise was to come up with ways to bring about universal health care in Illinois. So I say all this, shared all this to say that at the end of this 18-month process, $2 million spent with some really expensive consultants, a study was published. And how many of you have seen the movie Raiders of the Lost Ark? One of my favorite movies of all time. Okay. Remember when they found the Ark, right? Do you remember what happened to the Ark at the end of the movie? Well, that's what happened to the task force study. There were to be seen. In fact, I did an internet search about a year ago. I couldn't find it anywhere. So, at any rate, the other thing too, around that same time, there was also quite a few of our clients are public school districts in Illinois, and around that same time, there was the teachers unions were advocating for having all the school districts, 900 of them in the state of Illinois, all outside of Chicago public schools, to band together and form a common insurance pool. And you'll love this, acronyms, right, with government. They called this thing RESCUE. It gets better than that. Responsible school use of expenditures. You can't make this stuff up, man. Only in Illinois, right? But so and the spin was that, hey, we need to, it's the one concept a lot of the policymakers, not policymakers, because I'm talking about the politicians that don't listen to the policy, people like Heartland. One of the ideas, well, we just need to kind of band together a lot of people, and we're just going to drive down costs by having a large pool. And of course, for those of us who have a lot of confidence in state government here, are pretty relieved they didn't do this, because we know how things have been fiscally for the state of Illinois the past few years. But so there's a lot of crazy ideas that come out, and usually the spin is, well, we have a crisis and we need to fix it. And for the last 40 years with federal initiatives with healthcare reform, it's always that. I remember when I was just graduating, actually I remember this, when I was graduating high school, going to college, I remember Senator Kennedy got a bill passed called the Federal HMO Act. And of course, at the time, the reason for the legislation was there was a crisis. Costs were going up, what have you. And actually, one of the problems with costs with health insurance these days is, if you think about it, well, a couple of things. We've had, if you look at the way Americans get their health insurance, about half of us get it through employment-based coverage. And so we have this exclusion from tax, the employer exclusion for that. And I was amazed, Pam shared this with me, I wasn't aware of it. $260 billion cost in 2017 to the federal budget. It's even more than the mortgage interest deduction, which I found pretty interesting. But of course, the combination of that and also just the, that has really served to inflate, basically, I have all tax-free health care, and it's really served to kind of distort healthcare prices, and of course, and make healthcare very opaque, and third-party payment, especially I mentioned the Federal HMO Act, because what happened back then was all of a sudden these private businesses were given an authority to mandate businesses that they had to be offered at their places of employment. This is really government intrusion into private business. And but it really brought about managed care, and the whole myth that healthcare costs $5 copay for this and $3 for drugs and all that. So I think it's the combination of the federal income tax exclusion and managed care, and actually to this day, managed care in the form of PPOs is still very prevalent. So it's interesting, if you looked at early in my career, about 1981, 82, most health insurance plans that people were buying were, a typical deductible was maybe $250 back then. If you adjust that for inflation, it's quite a bit higher. It's probably about $700 today if you were to adjust that. But it's interesting because at that time, we were moving towards higher deductibles. I remember clients of mine going to $500 deductible, $1,000 deductible, like in the early 80s. Then all of a sudden, everybody just embraced this managed care idea, PPOs and low copays and all that. So over the last 40 years, the problem we have here is it's multiple causes, but a combination of the exclusion from tax and also the whole managed care thing over that period of time. So what I'm going to try to do today is provide some context and perspective about how we got to wherever we kind of comment on that, how we got to where we're at currently with our nation's healthcare system, with the high cost of insurance, offer my thoughts about where we may be headed near and longer terms, and then with some reservations, make a few predictions, but please don't hold me to any of them. For those of you who have been, it's interesting, 2 months ago, Nikki and Jim contacted me and said, would you like to maybe do something, a healthcare talk? And I said, that'd be great. Tim, give me your dates. And so I didn't want to do it right away. So the latest date was July 26th. And little did I know that the Senate would be doing these crazy deliberations the same week. I just heard today, by the way, that Rand Paul gave a great speech, but the repeal-only bill went down in flames. And so I think, who knows? Well, I'll get to that in a few minutes, some thoughts on that. So I already talked about the employer-sponsored insurance, the federal income tax exclusion. And by the way, that's definitely on the table, on the menu for possible considerations as far as the GOP. They haven't dismissed it. They're considering it. We'll see where that goes. I already talked a little bit about the lack of transparency, but it's both quality and price transparency. Yeah, really, if you think about it, we really have black box healthcare. It's not. We don't have a free market for healthcare. It's anything but. HSAs were certainly to move in the right direction, but even to this day, if you think about how health insurance is administered, sorry about that. Thank you. Thank you. So what happens with health insurance when somebody files a claim? The doctor doesn't really know what the cost is until the insurance company tells them what it is. It's just a very bizarre. The provider service isn't even that connected, and it's just the whole thing's very opaque. And what also helps promote that too is you have all these proprietary reimbursement arrangements with referred to by the acronym BUCA. And I spell BUCA, B-U-C-A-H, because most people spell it B-U-C-A, Blue Cross United Healthcare, Cigna, Aetna. But I give Humana some credit. They're the silent H on the end. But they control, the national companies, they control something on the order of probably 80 to 90% of the health insurance business. You have a few regional players, like in Illinois, we have Health Alliance in central Illinois. You've got in various states, in the Northeast, you've got Tufts Health Plan, Harvard Pilgrim. You've got, various. Kaiser is a very big HMO provider, which has actually been expanding nationally. But for the most part, I call it the cartel. The BUCA cartel controls a good part of the business. And it's so bizarre because providers of services really don't know what their negotiated fees are until the BUCA company provides them with an explanation of payment. Say, yeah, this is what it was. So that's a real obstacle towards free market healthcare. But I'm optimistic that that's going to change. So I'll get to my optimism toward the end of the thing. Hopefully you'll share my thoughts on that. So the one thing that's important, I provided a handout, by the way, that has some information. We actually built a page on my blog, johngarven.com//Heartland. And so for those who want to get deep into the weeds and look at, a lot of the things I talk about tonight, there's actual source material for some of this stuff. So I'm just not completely making this stuff up. But so anyway, anyone who really wants to is kind of wonkish or nerdish and you have too much time on your hands, you can check that out. But aside from that, though, I did include a few slides. In the second page, it's a pretty interesting slide. And this shows the sources of health insurance coverage in our country. And what's interesting about this, by the way, the data for this is from Kaiser Family Foundation, which is a really good repository of healthcare statistics and data. And this shows the shifts in enrollment between 2005 and 2015. So as you can see from the top, the employer currently, about 49% of Americans, actually around 160 million, get their insurance through employment. Now that was 54% a few years ago, but still, literally almost half of our citizens get insurance through employment-based coverage. Individual markets grown a little bit from 5 to 7%. And by the way, when they talk about repealing Obamacare and President Trump talks about the great disaster that is Obamacare, he's usually referring to the exchanges because the headline numbers here about the 100% rate increases and narrow networks and all that, that's pretty much in the domain of the exchanges. The other thing that's really significant, though, is look at the growth in Medicaid over 10 years. 13% 10 years ago, 20% now. It's a combination of Great Recession in the last decade, and then, of course, the Medicaid expansion under the ACA. Medicare has grown a little bit because people like me, I'm a boomer. A lot of us are retiring every day. They're reaching age 65, and so 14%, that's probably 40 some odd million people get insurance that way. And then you can see also the in other public, that would be VA and tribal plans and whatever. But I think that's a pretty good thing to understand as far as some of the societal changes and shifts, just the way people get health insurance. So I wanted to share that. So that's good just in terms of having context and perspective about how insurance is arranged currently. So question, is the ACA failing? So again, when Republicans talk about this, the law of failing, it's in large part making reference to the very clear failure of the insurance marketplaces and exchanges. In just 3.5 years of operations, they've only enrolled about 10 million Americans, 80% of whom qualify for federal premium and cost-sharing subsidies. Another slide in this little handout here, right behind that page, is this, it's really interesting, and I know you've heard a lot about the CBO, like the Republicans will come out with some kind of bill and say, oh my God, if this gets implemented, the sky's going to fall and tens of millions of people are going to be without insurance. Well, CBO, they're great people. They're given, they do static scoring. Tim would know because he was in the Congress, he knows how the CBO thing works. But you have a set of assumptions, right? And they build out models based on those assumptions. And anybody who knows anything about statistical modeling knows you just vary a few of those assumptions. I'm sorry, Jim Blakely, I told you I wouldn't do that. I'm sorry. But they can totally shift things. So I think it's pretty interesting. In 2000, this is every year since 2013, projections by CBO of what the 2016 exchange enrollment would be. So in 2013, before the exchanges were implemented 1/1/14, 24 million. Okay, well, 2014, its 2016 enrollment will be 22 million. Okay, 21 million in 2015. Okay, going into 2016, we'll have 12 million. Well, there's 10 million. So it's interesting if you think about it. We have 320 million people in this country, and boy, we really sure changed the whole infrastructure of delivery of health insurance for a very small problem. And by the way, pre-Obamacare, our firm does mostly employee benefits, but we also, as a matter of course, help individual consumers with individual health insurance. The things that Obamacare, the exchanges were supposed to repair, there really weren't. In fact, during our podcast today, we're talking about this. Is prior to January 1 of 14, 40 of the 50 states had state risk pools. Illinois had a very good functioning risk pool. So an individual who wanted to buy individual health insurance outside of employment, if they had a health condition, we had a program called CHIP, Comprehensive Health Insurance Plan. So worst case situation would be CHIP had a provision in it. If you didn't have prior coverage, you had a 6-month pre-existing condition limitation, but you can get coverage day one, but maybe your pre-existing wouldn't be covered for 6 months, but after 6 months, everything gets covered. Well, okay, that CHIP program was, in 1996, the federal government passed something called HIPAA. You've heard of HIPAA because you go to the doctor's office, you fill out a HIPAA form and all that. HIPAA stands for Health Insurance Portability and Affordability Act, or Accountability Act, whatever it is. The portability aspect of it relates to if people lose employment-based coverage and they had to buy coverage in the individual market, all these risk pools served as vehicles for people to buy insurance. So there wasn't a problem with pre-existing, and there wasn't a problem with guaranteed acceptance because you had that with these risk pools. You had that with the federal law HIPAA. So that wasn't really a problem. And I've been, until recently, actually my company that I'm now part of, I'll be enrolled in a group plan, I guess, come January 1. But I personally have had individual health insurance the whole time. And fortunately, I was a part of I had what they call a grandfathered policy. So I haven't had the experience that a lot of our citizens have had. In Illinois, first couple of years, 2014, 2015, you had Blue Cross has always been the major player in our state. We have probably, I'm guessing, 70% market share of Blue Cross, something like that. So they were offering full network plans, and premium was, it was not great, but it was manageable. 1/1/16, all of a sudden, the carriers are, in this case, Blue Cross Blue Shield of Illinois is part of a a consortium of blue plans. It's called Healthcare Service Corporation. They operate blue plans in Oklahoma, Montana, New Mexico, Illinois, and Texas, I believe. Last year they lost $300 million on exchange business. They're still in it, still doing it. So start going to 1116, what Blue Cross did and all the other blue plans around the country, and Aetna, all the BUCA companies were starting to offer narrow network plans. They're thinking, hey, we're losing our shirts, because the idea was, okay, we have this mandate, so all these young, healthy people are going to buy into this. That didn't turn out to be the case. In fact, 6.5 million opted out and just choose intelligently to pay I submit in many cases to pay the penalty, because it's a whole lot less than paying for insurance, which has a very high deductible, high premium, and if you're not, unless you're premium subsidy eligible, it's very expensive. My son, for instance, lives in Arizona. He was unfortunate enough to, Arizona was one of the states that didn't have a state risk pool years ago. 1117 premiums in Arizona up over 100%. The issue is this: in the insurance business, that's called death spiral. You probably have heard that in the news recently, where some of the politicians have talked about that, and it's true. If you have, when you're looking at a pooling of risk, if you have only bad risks in the pool, it goes into a death spiral from the standpoint that you can't charge enough money to actually run the pool and stay solvent. So that's what's been going on. And so right now, what's interesting is while the Congress is embroiled in what they're going to do in the near term, there's a lot of instability as far as the insurance companies knowing what set of rules they're going to be handed come 1118. And by the way, they have to know that really. What, Pam? Probably it's September, or is when they really need to have that information. So it's a real short window to really have their act together on this stuff. So I think something's got to happen probably in the near term, and we'll talk about that before I finish my talk. But it's really a mess. The point I'm trying to make is prior to the ACA, the promises that was intended to fix weren't. I think it. Jim asked me a question during the podcast. Well, how many people do you think this helped out? And I have no way of knowing it, but I think probably there's quite a number of people that got premium assistance. They're made too much money to be on Medicaid. It obviously helped some people, but it was a very small. It was like a rounding error when you look at 320 million people and maybe 500,000 people. Or I'm not trying to be insensitive to any person having a problem, but still, it's the cure was much worse than the what's the saying? Than the disease. Thank you very much. Okay, so the point I'm trying to make here is that prior to ACA, the individual market functioned pretty well, and we had federal protections with HIPAA to help that, and all we have now is we have less consumer choice. We have, I have another slide in the handout here that shows, for those that got the color handout, it shows in a graph of the United States, like something like, 49 counties without any options. Something like 40% of all counties in the United States have one or less provider of insurance. I know that in Arizona, where my son lives, there's one carrier, and they offer an HMO plan that has a very high deductible and very little, very, very small network. And in his case, he decided to enroll in something called a Christian sharing ministry. And it's interesting because it's actually under the law, under the ACA, you're able to enroll in this and not get an individual mandate penalty. It's really serving his family really well. Instead of spending $2,400 a month on a high deductible plan with a narrow network, he's now spending about $400 a month, and he's got this program, the Christian Sharing Ministry. He also bought a telemedicine program for $200 a year, and they love it. They're saving unbelievable amount of money. He called me and says, "Dad, $2,300. My mortgage payment's $1,600." So. Okay, so aside from the Medicaid expansion exchanges, for employers, there's been some real major costs and compliance burdens for employer-sponsored insurance. As far as the compliance burden, the main thing there has been for companies with 50 or more employees, there's been a requirement to provide coverage for anybody who is eligible under the law, 30 or more hours. And so companies have had to hire, whether it's our payroll companies, accountants, consultants, to do tracking and reporting, making offers to coverage, and also reporting on it to the IRS. And the IRS has the employers doing that because they're trying to track both the employer mandate from a compliance perspective, and then on the back end, they're trying to also pair that up with people who are taking coverage so they can enforce the individual mandate. Of course, if that gets repealed, then all that tracking and reporting can go away. But right now, what's being considered in the Congress are bills under budget reconciliation, and they could get rid of the penalties, right, Pam? But they would still have the reporting requirement would still be part of it. So that's been a real burden. Just an unbelievable amount of expense for employers to have to deal with that. Aside from that, though, there's been lots of taxes. I mentioned to Jim Lakely that if you're in the small employer market, company, let's say like Heartland, has you guys have less than 50 employees, right? So you pay something called a health insurance tax. It's like 2 or 3%. They just add it on, added cost. And, aside from that, though, then also in the small group market, there's something called modified community rating. What's interesting with this is that it's really you would think you would want to encourage young, healthy people into the pool, but it does the opposite. It actually cross-subsidizes costs from younger, healthier groups into older, sicker groups. We have a number of clients that are really young, male-dominated groups. And by the way, from a morbidity perspective, young males are pretty good health risks, right? So a lot of our clients that have more than, say, 25 or 30 employees, they saw 20, 30, 40% rate increases when this modified community rating went into place. And so what they're doing is they're actually looking at ways to getting around it, doing self-insurance arrangements, taking more risk. So it's all about, what do I need to do to avoid all the costs and complexity with the law? And it touches people at every level as far as how the law touches people. So I talked about the Medicaid, I talked about the exchanges, I talked a little bit about the employer compliance piece. That's pretty difficult. The other thing that Jim and I talked about today in the podcast was, and this is reality, 30 hours or more to be eligible for coverage. Well, that has an impact on the way jobs are offered in this country. I know in my own church community, there's quite a few people who work 2 part-time jobs to have full-time hours because nobody will hire them full-time. So, and it's totally to avoid the employer mandate. So that's a perverse incentive, certainly. So I talked a little bit about how the market worked pre-ACA. One of the problems too with the law too is between the codified law and its regulation, it's really incoherent. I mean, the law when it was passed was 1,000 pages long. It's estimated that the total number of pages of regulations are north of 40,000. They're talking about tax simplification, and I heard Tim probably would know more than 75,000 pages of regulations in the tax code. I mean, ACA is going to get there, eclipse that in no time at all. I mean, it's only been around for 7 years, right? Since the date of the law's enactment, there have been 70 changes or delays that are documented. And by the way, Galen Institute, which is an organization that has affinity to the Heartland Institute, has a really good page about this on their website where they document all this. But 70 changes or delays are documented. 43 that were done by the Obama administration, 24 that Congress passed and the president signed, and 3 by the Supreme Court. And so, the law is like Swiss cheese. I mean, when you talk about the ACA, it's the other thing too is that the law that we have, the law was actually the Senate passed version of the law that we got on Christmas Eve 2009. I remember, getting ready for Christmas and thinking, thank you very much, nice Christmas present. But that law was a shell bill, and it had 1,000 occurrences of the phrase "the secretary shall," so it was kind of like, we'll get back to you with the details at a later date. So, and actually in some respects, so now that President Trump is our president and Tom Price is the HHS secretary, they actually, to the extent that ACA still sticks around, they're able to promulgate regulations and kind of interpret it and bend it in a different direction. But it's just a very flawed law. It's a very incoherent law. The other thing that's a rub too is the for those who don't get premium assistance on these changes, if you're buying insurance in the individual market, if you don't get the premium subsidy, premiums are after tax. So if you think about this, prior to 1/1/14, a lot of businesses were actually offering individual consumers opportunities to buy individual health insurance, but do it through something called a health reimbursement arrangement. So people were able to pay premiums pre-tax, and now those same people are paying it post-tax, and the premium is up over 100% on average in that period of time. So it's just an ugly situation all along. So I said all that to totally depress you, and hopefully dessert will help take care of that a little bit later. Okay, so the politics of healthcare reform. Really, this is kind of like the third rail of politics, right? Social Security, Medicare, and healthcare reform. We saw it with the Clintons in 1993. President Clinton came to be inaugurated, and he put his wife Hillary in charge of healthcare. And after Harry Louise and the whole tedious process that was, it was just a miserable failure. And of course, he lost the midterm, 1994. And that was the, if you will, quote unquote, the Republican Revolution at that time. Contract with America, Newt Gingrich, and all that. So, and then of course, Obama in 2009, he actually had, when the bill was passed in the Senate, he actually had 60 votes. So they were able to get the Senate bill passed through regular order, because they have these really arcane rules, and you're hearing about it now this week. The Senate has all these, Senate parliamentarian, they have all these, the filibuster, the cloture and stuff, the 60 votes, and I'm still trying to wrap my head around it. I thought I knew about it, but Pam and John Greener, his colleague, are helping me understand a little bit more, but it's just really bizarre. So anyway, what happened there was that, of course, 7 years ago, the law was passed through reconciliation, which is the same process that the Republicans are trying to use to make changes to ACA at this point around. So now, of course, what happened with Obama, people like Tim got elected in 2010. The Tea Party movement, the Tea Party was officially birthed, as I recall, after Rick Santelli went on his rant on CNBC about tax enough already, and April 15th, all of a sudden, all these rallies, and so obviously Obama lost the midterm, and then eventually it ended up costing him the opportunity to do a Supreme Court pick toward the end of his administration. So healthcare is really a dangerous territory to venture into if you're a president, especially if you're just going to try to serve a couple of terms. So Trump, this time around, he kind of left it in the hands of Paul Ryan and Mitch McConnell to figure out. And it's interesting because the House bill passed May 3rd, vote of 217 to 213. It was just an engineering marvel to see how Speaker Ryan got everybody together on that. And then, but they failed in March, right? They didn't get it done in March. They came back and got it done in May 3rd. Same thing with the Senate. So they, somehow, I knew when John McCain was traveling back after having this horrible diagnosis that the vote was going to be there, and they were going to be able to at least move this thing along to debate. But so far, what we know from the last 24 hours, the BCRA, the Better Care Reconciliation Act, the only government comes up with the acronyms and names like this. That failed, 57-43. Today, Rand's bill failed. So I think at this point we're moving towards something called a skinny repeal bill, and I'll talk about it in a couple minutes. I made mention of the the budget reconciliation process. That's kind of interesting. I kind of looked into that, a little bit of understanding of the history of it. It actually has been around since 1974. Its reconciliation allows for expedited consideration of certain tax spending and debt limit legislation. In the Senate, reconciliation bills aren't subject to filibuster, and the scope of amendments is limited, giving this process real advantages for enacting controversial budget and tax measures. And I'm reminded by this post I was looking at that the legislators have used this 20 times for 20 budget reconciliation bills since 1980. COBRA, the Consolidated Omnibus Reconciliation Act of 1985, which gave us the continuation law, was part of a budget reconciliation. It was used to enact major spending cuts during President Reagan's first year in office, the Bush tax cuts in 2001 and 2003, and of course in 2010 to pass the ACA, as we know. But it's kind of ironic if you think about it, that Republicans decried the fact that in 2009 that the only thing that was bipartisan about the ACA was the opposition to it. Now 8 years later, the Democrats, I guess, can say the same thing, I guess. But so public opinion per Gallup, this is interesting. The more we've been talking about the ACA repeal, the more popular this law is becoming in the polling. Actually, the ACA's popularity is an all-time high. And in a Pew Research poll conducted last month, a majority of Americans now believe that it is the federal government's responsibility to provide health care for all Americans. And that's the slippery slope that concerns me, because I think if we get the point, it might be a tipping point where if people actually literally believe it's the role of government to provide this, that's definitely a concern for lovers of liberty like we are. So then, what about single payer? We've heard, Bernie Sanders on the campaign trail last year talked a lot about it, and obviously it represents a utopian dream for many in the far left. I could be wrong, and I just don't see us ever, as a country, ever adopting this for any number of reasons. But just most recently, I think it's interesting that single payer initiatives within the last year have failed in California, Colorado, and Vermont. California just recently, then in June, actually. Had it in their General Assembly, and the House Speaker he pulled the bill. And basically, if they would have implemented it, it would have cost the state twice their annual budget. And you'd think if it get passed somewhere, maybe that would be a place that you might see it. Colorado had something called Amendment 69. It was a statewide referendum on the November 16 ballot, and it was voted down 4-1. And then most recently, I think it was interesting, is that Vermont actually had a single-payer law in effect. It was enacted in 2011, and it was built on by Governor Peter Shumlin in December of 14, and he cited big tax increases of 11.5% on payrolls and another 9.5% on individuals' income, and it would have come up with hundreds of millions of dollars short to finance the thing. And this is for a state that's a little bit bigger than McHenry County, population-wise. It's 625,000. I think my county I live in is about 500,000. So it's pretty homogeneous. You'd think if they can get it done, they can get it done in the Green Mountain State, Mountain State, but apparently not. Then the other thing that's been interesting recently, last couple of weeks, is all this stuff we heard about Charlie Gard. I was thinking about single payer. So first of all, I mean, what that family's had to go through is unbelievable. Best as I can tell, it sounds like if he would have gotten treatment early enough, he could have actually survived. And of course, all this nonsense with the government, that didn't happen. So they came to the conclusion it's too late. And then recently, this morning, I heard that now the guards are trying to figure out how to get the government to let them bring their son home to die with dignity, which is just unbelievable. So I think if for what it's worth in the future, if we have a turn and we have a bunch of advocates for single payer, I would think that's in recent memory, and we can hang on to that, because that's an outcome, I think, eventually. I think some of the things that, as far as possible good ideas in the future, I think I personally have loved my HSA. I've had a health savings account since they've been around since 2004. I feel really empowered as a consumer. It really bothers me that the pricing, as far as transparency, is very opaque, but there's emerging some services where you can get some more transparency around pricing and quality. I think the private market's going to figure this stuff out before the legislators ever actually conscript something for us to use. But and one thing that, for what it's worth, the American Health Care Act has some really nice expansion to HSAs. And I think, Pam, you can correct me, but does it unbundle the requirement to have a certain kind of health insurance plan? Do you know offhand? I don't mean to put you on the spot, but yeah. So I think that's a common theme in most of the HSA expansion, which would be wonderful. So personally, I've had an HSA since 2004, and I've got a $5,000 deductible, but I've been able to accumulate about 20 grand in it, and I feel like I'm really empowered. I mean, I can pretty much go anywhere I want, and it's a good feeling. And I think everybody should have an opportunity to participate in something like that. So I think from a policy perspective, I see that's a real winner, and I think actually there's some bipartisan support, right, for expanding HSAs. I think we're moving towards high deductible health insurance anyway, so even some of the moderate and towards the left people on the side of the aisle can see that there's a need for people to be able to manage the risk of their higher exposure to costs and all that through that. So what's working in today's market despite the ACA and all this stuff? I mentioned we do a lot of work with self-funded plans, larger employers. What's interesting is there's a lot of data around the fact that when you encounter healthcare in this country and you have a major matter you need to deal with, it's really unfortunate, but there's a lot of misdiagnosis, and that really leads to a lot of problems. In fact, Mayo Clinic published a study recently, and it's posted on this webpage. 88%, they reported as many as 88% of the patients go home when they come to Mayo Clinic with a new or refined diagnosis, changing their care plan and potentially their lives. Conversely, only 12% received confirmation that the original diagnosis was complete and correct. And digging deeper, in 21% of the cases, 1 out of 5 cases, the diagnosis was completely changed. And 66% of patients received a refined or redefined diagnosis. So this really does speak to the issue of healthcare quality. Very disconcerting, but I will say there are care management companies I'm starting to see that are beginning to provide service where you can basically kind of care managers to help coach people to make good decisions about where to go for health care and that sort of thing. But it's referred to kind of under the heading of care management. We are starting to see some transparency tools come to market. There's a number of companies that are doing that. It's interesting now, to show you how crazy the managed care business is. There's a Blue Cross Blue Shield of Illinois, I probably shouldn't name companies by will. They have a very broad PPO network in this market, but the price variability, you can have, like, take an MRI. The MRI, the price variability can be, for as little as $300, as much as, $7,000. So they have a program through a company that actually rewards people through their care management program thing. But if they get care and are able to document savings, they're getting a percentage of it as a bonus. And I think that makes a lot of sense. But it's kind of weird if you think about it. I mean, you've got the variability in pricing for the same thing, and that goes to the point of becoming more engaged as a consumer. But I'm not going to be more engaged as a consumer if it's black box opaque healthcare, and first hour, and I'm not thinking about I'm thinking that the office visit is $20 and all that. So, which speaks to the need for more consumerism. A couple articles I posted on that webpage about direct primary care, no third-party payment, concierge primary care. Love that. That's coming into really coming in a big way. Telemedicine is wonderful. We have a lot of our self-funded clients that are actually offering at a very low price point subscriptions to a telemedicine provider where for basic stuff like sinus problems, respiratory infection, allergies, urinary tract infections, cold, flu symptoms, and non-emergency illnesses, they're able to do video chat or telephonic consultation with a doctor. Another thing too, it's interesting that I mentioned my son's situation. Since the ACA's passage, health sharing membership has gone up 5-fold from about 200,000 to over 1 million today. So, that 1 million is still a small number in relative terms, but that speaks to the that's an alternative means of arranging the way you finance healthcare. And then finally, some observations and predictions. So the ACA was mostly aimed at the financing of healthcare and changing how the individual market in particular was structured, but it did very little to address the actual cost of care. And so health insurance is expensive because healthcare is expensive, but that's a topic for another time. Again, the third-party payment, many of our cost problems are exacerbated by the lack of consumerism, which can be easily explained by the black hole that is third-party payment. I also believe that healthcare and financial literacy, or lack of it, are real problems. And maybe there's some more things we can do in terms of educating high school and college on how to be better consumers. Of course, they're not incented to be consumers until we have a consumer system, which you don't have. So there's some policy ideas I'm sure Heartland can help frame in that regard. I was very surprised when Senate Majority Leader McConnell pulled a rabbit out of the hat and managed to get a 51 to 50 vote to get this debate opened up. And by the way, under rules of budget reconciliation, there's a 20-hour window. So my understanding is it's all going to be done like by tomorrow or this weekend or something like that. So I already talked about the BCRA has been voted down. The the clean repeal has been voted down. There's talk about the one thing that I think might be the backstop that might actually have some opportunity to get passed. It's called a skinny repeal that would repeal the individual employer mandates along with the medical device tax. And this is kind of a tactic that would at least buy the Senate GOP leadership some more time to set up negotiations to secure a compromise. And when you go through the conference, because the House actually has a bill that was passed that is a very broad bill. So regardless of what, if anything is enacted, there will be at least a 2-year transition period. And so probably in the meantime, I mentioned these exchanges are blowing up. Congress is going to have to do something to shore up that on a short-term basis to prevent the complete collapse of that. And it's interesting. I think I'll predict that nothing's going to be done yet with the employer federal income tax exclusion. I think it's going to continue for the time being. There's something called the Cadillac tax, which I think will be delayed. There's bipartisan support to repeal or delay that till 2025. And then I really hope the HSAs will be expanded. And I think there's good reason to believe it will. So other than the above, there's little that anyone can really be really sure about in the very near term. And I just want to close by sharing something from our good friend Greg Scanlon wrote a book recently called Mythbusters: Why Health Reform Always Goes Awry. And I just want to quote out of his book. Nearly every reform that's been embraced over the past 50 years has failed. Actually, not just failed, but made conditions worse than they were before the reforms were adopted. With every new iteration of policy, the providers of services have to run out and hire attorneys, accountants, software programmers, and compliance officers just to avoid running afoul of these new rules. Of course, this all costs a great deal of money and contributes absolutely nothing to patient care. The ACA is a compilation and doubling down on all the mistakes that took place in the previous decades. And I'll add to Greg's observations that regardless of the final outcome, we are probably at risk for more of the same with what's currently being debated in the Senate. But I know earlier today, Joe, I think Tim and others were talking about, hey, it's going to, the action's at the states. That's where things are going to change. And it's an interesting time we live in, but I don't want everybody to be bummed out. I think there's a lot of reason for optimism. I think Joe mentioned to me earlier today that the environment, we have a lot of libertarian and free market types are in the administration, and there's a lot of reason to be optimistic. So that's all I had to share. I'm sure there might be some questions, comments, remarks.
Well, thank you. Let's thank our speaker, please.
Thank you.
Okay, so if you have a question, we have professional Q&A people here at the Heartland Institute. You raise your hand. They will come along with a microphone. We ask that you identify yourself so that John knows to whom he is speaking. And if you have questions online, in my pocket is my phone. I'm monitoring both Facebook and YouTube. So you can leave a question in the comments, and I'll be happy to read it for you. And we will start right here in the front.
Hi, I'm Nancy Thorner, and I'm just wondering, there are so many great ideas that I hear that doctors are offering across the United States, and they know what is best because they're involved in it. Why aren't the senators and the representatives listening to them with their ideas that they have?
Politics? I think this whole vote right now that's going on, Jim and I were discussing this in the podcast, is that the Republicans ran on repeal and replace for the last 4 election cycles, and there's going to be hell to pay regardless, I think, but it would have really been hell to pay if they didn't get a vote taken and moved to the debate. And unfortunately, we're caught up in the moment, and there's nothing long term or forward thinking about any of this stuff. It's really like a wild, wild west. I was watching C-SPAN last night. I was actually watching C-SPAN. In fact, at one point, I mentioned to Joe Batts that the Senate Democrats actually required that the 178-page Senate bill be read aloud. So it went on for 4 hours, and I kind of put it off to the side, and I turned it back on, and Ted Cruz is on, so I listened to him for a little bit, and then. But unfortunately, it's all caught up in the politics, and that's the problem. It's I wish I could say that the politics, we can get past it. But there's something more that is more at stake, I think, than healthcare in terms of 20% or approaching 20% of our gross domestic product. That's a big number, and I don't know. It's
But I'm thinking of solutions that they could adapt to incorporate what they're doing.
yeah. So solutions. The problem is that if you think about the last 40 years of healthcare reform, they've to Greg's point, they've just layered things on top of things on top of things on top of things that it would take a major rotor rooting to get rid of some of the crap that's down there to bring about free market reform and market-based reform. But I don't really answer your question, but it's politics, I think.
Raise your hand if you have a question. We're going to go right over here, and then we'll go around the room.
Yeah.
Anthony Ciani from
Hi, Anthony.
Palatine, Illinois here.
Hi.
So one of the things I've noticed in the great healthcare debate is the massive amount of misinformation and malinformation. For example, someone says pre-existing conditions. I had a friend who was unaware of the high-risk pool in Illinois because no one ever told him. But he couldn't get insurance because he had a non-cancerous possible tumor, benign tumor, and that had never harmed him for 20 years, and so he had a pre-existing condition. And 90% of people would say, well, no, that's wrong. He should be able to get insurance. The person with cancer in remission for 5 years has pre-existing cancer and can't get insurance. Whereas other people look at you and say, well, you just found out that you have a carcinoma, an active carcinoma. Well, that's a pre-existing condition. You should have had insurance. And even I look at the Kaiser polling and that you handed out, and it just screams out to me that these numbers are invalid. And the reason these numbers are invalid is printed at the bottom of the poll. Is everybody who thought that Obamacare should be repealed, which is about 40% of the population, was omitted from the poll. So how can, when we've got poor or malinformation like this coming down on top of congressmen, and they don't know that 60% of the country wants Obamacare gone or fixed, how can we get any kind of action?
Yeah, I think one of the problems and Tim would know this from having been a former state rep and congressman, but is that they're dealing with a whole host of issues, not just healthcare, and they rely a lot on their aides, and of course some of this is their political ideology that goes into their worldview and what the role of government and responsibility of the individual. I don't know if I have a good answer, but it's a good comment. It's well put. Problem with polling is a lot of the way the questions asked and all that too. Absolutely.
Hi, I'm Carrie Espinosa. I'm the legislative chair for Anahu Association in Chicago, and I'm also an insurance broker, so I'm kind of up to my elbows in this craziness with you. I have two questions. So my first question is, you commented that part of the cause of this was the federal income tax deduction in managed care. So I'd like you to elaborate.
Well, it's created the black box effect of lack of transparency in pricing.
Okay, I agree. Yeah, I get that. Okay, so then my other question is, so yesterday afternoon I'm watching the news, right, and they passed the negotiation discussion piece. Then last night there's another vote, right, and then today another vote. Most consumers don't know what's going on. Even me in the industry, I got to tell you, I'm kind of like shaking my head. What else is coming? Yeah,
so a lot of senators don't know what's going on, right? I mean, they're looking at the Senate parliamentarian, how do we deal with this? And they had the bird rule, and Pam was sharing some things with me earlier. It's crazy. And I thought I was knowledgeable about this stuff, and I'm not. I mean, when I don't have a good answer. I'm sorry. Consuelo, how are you doing?
Tucker from Fee Magazine. An American got sick in Europe, very sick, and the care that would have cost him over $100,000 here cost them. He was afraid because of all the zeros in the foreign money. It came down to $7,000. Full body MRI. I don't remember specifically. Jeffrey Tucker, you can look it up in Fee Magazine.
Medical tourism.
Well, he just happened to get sick there. But there are people going over there because they can get what costs a horrible amount here.
Yeah.
Something has to be done about that. And the cost of drugs. Drugs don't cost as much anywhere else in the world as they do here.
Yeah.
They don't.
Well, we're
It's-
basically cross-subsidizing the rest of the world with our research, and I mean, you think about it, it's pretty gross. It's unjust, it's not right, yeah.
But you don't see that, why is it costing, it would have cost him over $100,000 to have that same care that he received over there. It cost him $7,000. There's something
That
wrong
would be
there.
a case for medical tourism, I think, right? I've been to Costa Rica, by the way, that's a great place for medical tourism,
That
but,
doesn't address why it's
yeah.
so expensive here.
yeah.
Even when you talked about the disparity in, you can get it for 300 or you can get it for.
Well, again, that's been, Consuelo, that's been caused by a couple of generations of black box, healthcare. That's what the outcome is, I think. We don't have a consumer market.
Yeah. We're going to go over here.
Hi, John. Tom Sadeka.
Hi,
I've
Tom.
got a payroll company, Precision Payroll of America, and I do want to say the Affordable Care Act employer reporting is a pain in the ass.
Yeah.
And my
That's
question
being kind,
is,
yeah.
here we go. All right. With the executive order Donald Trump passed pretty soon after he took office, saying no individual or company should be burdened, the ACA, why can they not suspend the employer reporting or the B form reporting from the insurance companies? Because that truly is a burden. So that's the one question for our lady from the organization. John, you're going to have to clarify again why, because we don't pay income tax on our insurance benefit, it drives up the rate of insurance. You mentioned it as a cost driver.
Yeah, I mean, so you have companies are over the years, with tax-free health insurance, you negotiate a lot, and of course, in collective bargaining, you're not in collective bargaining, but benefits have been negotiated, and over time that has it distorts the market. I mean, it has a distorting effect on pricing and
So
transparency.
if we're to begin to pay taxes, which is
No,
intended.
I'm not advocating paying taxes at all, but I think.
No, but I'm saying that will help clear up
I think
or make transparent
employers
pricing?
would figure it out, and it would maybe go up, if there's a cap, for instance. I would think that employers, to the extent they still are in the game providing benefits, would figure out a way to deal with that.
Okay. And my third question, I'm sorry, I'll be done. Seems the most popular plan in the exchanges has been the silver plan.
Yeah.
And there's also the bronze plans. And those are carrying now deductibles of $6,500.
Yeah, the bronze plans, yeah.
And an out-of-pocket maximum of $65,000 to $7,000.
Yeah, it's more than
Per year.
Yeah, more than that even, yeah.
Is that where they're talking about reimbursing the insurance companies when
Yeah,
the
yeah.
low-income folks
Yeah,
are
so
using it
low-income
and they
folks
can't
get-
pay the deductible, they can't pay the copay?
Right. Yeah, so they get this thing called cost-sharing reduction, and they get, if you will, a plan that's suited to them, their income, and they're paying less towards deductible, less towards out-of-pocket, and all that.
Thank you.
Yeah. Yes, sir.
Let's go right here. We're going to go to people like, John, we need to have people
yeah.
with microphones. It's going to be
George
George right here in
Clues.
front.
Yeah, George Clues.
Hi, George.
From Mount Prospect. It's really more of a comment than a question, but in terms of getting Congress to do something, one of the things that fries most people is the fact that Congress doesn't apply its laws to itself.
Right.
And the Affordable Care Act is a classic case where Congress is classified as a small business to get, to allow it to get benefits under the ACA. And I think one of the things that President Trump should have done was to say, we're going to take away this fake classification from Congress, and in 3 months' time, Congress will have to live under the Affordable Care Act. And I was just wondering if, you'd like to comment on that, on how they got that, that dispensation.
Pam can probably answer better than I could. Not to put you on the spot, Pam, but yeah.
In the law, it said that certain people in Congress had to be part of the plan. And then if they had them purchase individual coverage because of what the IRS did relative to health reimbursement arrangements, then they couldn't have benefited from those being pre-tax dollars. So the only way for them to be able to pay for premiums with pre-tax dollars was to consider them to be
A business.
small businesses.
Right.
I do believe, and I could be wrong on this, but I think there may be a lawsuit still percolating out there about whether or not they should be considered businesses, that's not indeed correct.
Well, I would think that, to your point, sir, that that would certainly motivate them to do something about the law, right?
Okay, we're going to go over here.
Thank you. John, you did a terrific job.
Thank you.
And thanks for Heartland again. This summer, after an overseas trip, I came back and I wasn't feeling well, so I thought I'd better have a physical. I haven't had one for a while. I went in, they took my blood and x-rays. They put me through a tube and they didn't like what was on my leg and they gave me all kinds of things. The bill was $13,000. And I didn't have to pay for that. Insurance, I paid a little bit, not much. My wife wasn't feeling well, so she went to the doctor. They put her in the hospital for a couple days and all kinds of tests. She's here tonight. I think she's quite healthy. We have a friend from Mexico who has a grandmother with cancer. So they brought her here, and she gets free help for her cancer. And, you know, I want to take care of people. I go to Addis Ababa and see a friend of mine, and he has a new baby there, and he shows me the new baby. Where is that baby born? In Hennepin Hospital in Minneapolis. And most of his friends in Addis Ababa come to Minneapolis, have their babies. That hospital used to report to me many years ago. Minneapolis has over the Twin Cities 100,000 Somalis that come here.
Right.
And they all get free health care. So I guess my question is, how can we afford this? People are clueless. I don't think they know this. And by the way, these in Addis Ababa, when these kids that are now American citizens become 21, they can bring their parents here and put them on Social Security, even though they haven't put a dime in Social Security. So help me. And when I speak out against this,
Wow.
Guess what? I'm a white racist. I marched with Martin Luther King, went to his funeral, but I'm a white racist because I don't think this is right. Help me. Help me.
Amen, brother. That's all I wanted to tell you. We're preaching to the choir. I don't pretend to have any. It's unbelievable if you think about it. You know, it's unjust. It's an injustice. It's not equitable to the citizens of this country. I agree. Yeah, but people don't know about it. You're right about that. I didn't know about the Social Security thing. That's new to me. Okay. Yes.
John, I have a question here from a viewer online.
Okay.
Raquel Betancourt asks, do you foresee
I know her.
do you foresee the Affordable Care Act being repealed this year?
No.
No. Would you care to elaborate?
Well, okay. So so I spoke with Pam's colleague yesterday, John Green, and John was sharing with me that once this thing gets to to a House conference committee, let's say the Senate's successful in passing a skinny repeal, then it goes to a conference committee. My understanding is that most of the time the Congress will have something called a pre-conference agreement, but they don't have it this time around, right? And so John described it to me, it's like the Wild West when it comes to the conference, and then the minority party will have an opportunity to be very much involved in what the final product that comes out of that. So I think the best we can hope for is repeals of certain aspects of it. I mean, I would love to see the employer and individual mandate go away. The employer mandate is just a compliance juggernaut. The individual mandate, I still can't believe that Justice Roberts voted with the minority on the Supreme Court on that thing. But then in the interim, the near-term thing that has to be done is what are we going to do about these exchanges that are blowing up? So I'm not a fan for throwing good money after bad, but there's something that needs to be done. And I know that I haven't really studied Pam, but I know that NAU has some policy proposals around market stabilization with regard to the exchanges, but I don't know if you heard. Okay, do you have knowledge of that particularly? I've been put. I'd really like to have Pam to share that, because that's an important point of this whole discussion. And if you can get a microphone to her, that'd be great.
I'm going to disagree with John, because if they don't do something, I'm going to disagree with John, because if they don't do something, tax reform won't work.
Oh, yeah, yeah.
And that's really critical for the Trump administration as well as for the Republicans. So whatever they do, we may not call it repeal, but that's what it will be called.
It will be spun as repeal.
Yeah.
It will be some minor kind of incremental way towards that, but nothing like a full repeal and replace. That got voted down, earlier today by, Rand Paul's ideas.
Okay, we have time for a few more questions over here.
Larry Greenberg from Skokie.
Thank you, Pam.
Looking at your chart, which shows that 84% of the people are kind of taken care of by the employer insurance or government programs. Looking at your other chart that says that people are looking to do something. Looking at the fact that Obamacare created this big jump in entitlements,
Right.
how can you be optimistic that we won't go to single payer? And responding to the expert who made the comment before, if you don't know what's going on and she can't explain it and I can't explain it, why wouldn't people say, wash my hands of it, let's go to single payer where I can understand it. I get a card, I go in, I'm taken care of.
Well,
Bang.
okay, you have a card. That doesn't mean you get taken
Wait,
care of.
one
but yeah.
corollary question. If we go to single payer,
Yeah.
what happens to the medical insurance industry?
They'll be hired to administer all of the claims. Or Buca would probably be logically the new. They'd make it a government agency. Yeah. Right. Because they have the infrastructure in place to administer that. But the problem with single payer is this: what single payer are you talking about? I mean, if you look at all the Western developed countries that have, if you will, a form of single payer, they're all over the map as far as the flavor of it. I mean, there's this fallacy that people think that, you hear the stat, well, we're the only country in the Western developed country that doesn't do this, that, and the other thing. But as far as I know, the only two countries on the planet that prohibit any kind of free purchase of health care would be North Korea and Cuba, I think. So, so that the Canada system, if you have means, you come to the United States to get health care. So I don't know. I don't think there's it can't get done in California, and they've been trying this for the last 25 years, 7 times, and I would think that if and they it certainly couldn't get done. Who knows? God only knows. Yeah. Yes, sir.
We have another question over here.
Yeah, I just wanted to make a comment. Michael Howard from Palatine.
Hi, Michael.
You spent an hour talking about this subject, which is interesting and everything. But really, at the end, you said it's all about politics. And I think but anyway, I think that is the whole bottom line of everything. And politics is about power over people.
Yeah, I agree.
And you think Washington cares about anybody in this room? This lady's talking about a 7,000 thing versus this, and this gentleman's talking about his business. They don't care about us.
No,
I swear. And that's what we have to realize.
Yeah. To quote Peter Schweitzer, throw them all out. Yeah, good.
Okay, we have a question right over here. John?
Yeah.
Whenever I'm in doubt, what would Milton Friedman say? so I looked it up, and he made a speech about health care in the 1990s, and see if you agree with this. He believed that if government never got involved in health care, it'd be much, much cheaper today.
Oh, yeah.
But he said it's impossible for the government to get out. So his suggestion was give everyone, if they wanted it, at least a catastrophic care policy financed by the government.
Yeah.
What do you think of that?
Let people have HSAs and then catastrophic. What did he define back then as being catastrophic?
He didn't give a great definition. Catastrophic care, where you would get. He didn't say anything about the deductible, but it would. It would probably be somewhat of a high deductible. Maybe the government would subsidize that, but it would cover catastrophic. You have a child that has cancer. They don't need to have a pie social in order to pay for the kid's care.
Well,
to cover something
that
like
sounds
that.
better than let's say you're 2017. You're on the exchange plan. You've got a plan with a $13,000 family deductible, and you know, it can't be any worse than that, right? I mean, but, and you have narrow networks, and so I don't know. I think I love Milton Friedman. Anytime I run to somebody that doesn't understand anything about free market economics, I put on YouTube, 4 ways to spend money, there you have it. And so Uncle Milt, I love Uncle Milt. What's his face? Charles Murray had an interesting concept about 10 years ago about you know, taking the subsidy that's in government towards all these benefits and just giving people money, and that's an interesting concept. John Cochran from University of Chicago has some really good free market ideas that involve something like that. I posted his paper on the blog page that I made everybody aware of. So I think those are conversations we need to have and discussion we need to think about.
We have a question back here. We'll have time for one more after that if you want to raise your hand.
And my question is really more of a little history lesson, but in December of '88, I was diagnosed over the phone by my doctor with what he thought was a serious problem when I had pure insurance. And he said, go to the hospital like ASAP and get this checked out. And it turned out I had 3 ulcers. But I went to the hospital immediately. I got test run the next day, another test done the day after that. Very rapid, and figured out what was the problem, and they gave me medicine to fix it. In comparison, 20 years later, I was in the VA health system, and my doctor thought, you've got a problem, we ought to get a chest x-ray done on you. And I went to the hospital the next day to get a chest x-ray. I think it was 2 days later. So the day before Thanksgiving, the doctor said, you need a chest x-ray. Friday, I had the chest x-ray, and they didn't read it until December 22nd.
Oh.
And then they decided that I needed a CAT scan to follow up on the chest x-ray, which didn't happen until February. Then they decided I needed to have a PET scan done to follow up on that, which was done in March. But it was a 3-month delay between the first test and the last test, all because of the bureaucracy.
Right.
And when I finally got the bill from the PET scan, which was done at a place in Des Plaines, they billed me $3,600. Now, the VA was billed for that $3,600 also. And 3 months later, the VA paid the bill and told me they were paying $1,200 to the CAT scan place, and they weren't allowed to bill me for the difference, the $2,400, which, of course, they did bill me for the difference, and I had to fight them on that. But that's the difference of what goes on with a single-payer system, which is what you've got within the VA.
Yeah.
And let me just close by saying what insurance rates I paid as a college graduate in May of '74. In May of '74, I was part of a group health plan with Blue Cross Blue Shield. I had to pay the whole premium myself, but it was not subsidized.
Right.
And as a single person, and I remember the number so well because the number happened to end in 666, but it was $16.66 was my single health plan coverage with Blue Cross Blue Shield. If I was married, it would
semi-monthly or
no, that's $16.66 a month.
A month. Oh,
in May of '74.
Wow.
And if I was married and had 6 kids, like the pastor of our church, it would have cost me $28 a month.
Sweet, sign me up.
That's in May of '74.
Yeah, right.
Blue Cross Blue Shield, a Cadillac plan in those days.
Yeah, right.
What happened in the meantime?
Yeah. Wow. Yeah.
All right, this is going to be our last question. Please identify yourself, sir.
Yeah, Henrik Kowalczyk.
How you doing?
Yeah, how you doing? And I have a little bit of comment referring to one thing which you said, and I would like to kind of elaborate on it, because you mentioned that it looks like that many Americans right now believe that the government should provide health care.
Oh, polling.
So what my conclusion out of that is, and I would like your comment, is that what the voices here, which was that is the politics and whatever, well, we elect a representative to represent our opinions. If most of Americans believe that the government should take care of our health, then they should keep ACA, means Obamacare, in force, because they represent most of Americans. So otherwise, the problem is not in politics. The problem is to go to your neighbor and convince him or her that unfortunately what you ask for, believe in, is an illusion. Like,
Right.
The gentleman explained on the example of, single payer
Absolutely.
in the veteran, and we all can bring our examples.
So bring all your neighbors to the next Heartland event, and we'll get them thinking right. Thank you.
All right. Thank you. Let's give our speaker a round of applause.
Thank you.
All right, thank you. Thank you all for being here. I just want to say two quick things before we send you away. On your tables, you're going to see a How Did We Do survey card. This one is already filled out, and yeah, we got pretty good marks. That's good to see. So you can fill this out yourself. This really does help us. We love the feedback from newbies and regulars alike, so we can continue to improve our programs here for you. And also on your tables is a flyer for our Picnic for Freedom, which is on Saturday, September 9th from 3 p.m. to 7 p.m. right here at the Heartland Institute. When we had our grand opening in 2015, we had an enormous picnic all day long on Saturday, about a month after we moved in. It was a huge success. The Heartland Institute's not going to have our benefit dinner this year, which we've done in years past. So this is going to be the big event for Heartland this year, and it's a great welcoming picnic for our new president, Tim Hulskamp. So it's a great chance to meet him. It's a great chance to bring your family. We're going to have games. We're going to have a lot of fun. There's going to be plenty of food and lots of activities, and on a wonderful, I'm sure it will be a wonderful, sunny, beautiful, fair September late summer day. And we really hope to see you there and help spread the word and get even more people around here. That if you've never brought anybody to a Heartland event, a great picnic is a great introduction to our organization and to all the friends you've met here. Thank you all so much for being here tonight. We'll see you at our next event in August. Bye-bye.